It is my pleasure and honor to introduce our afternoon keynote speaker, Dr. Richard Ferguson. Yes. He grew up in Washington, D.C. and Pittsburgh, Pennsylvania area. He went to undergrad at Northwestern University and to medical school at the College of Human Medicine at Michigan State University. He is board certified in family medicine and has practiced emergency medicine in rural and critical access-based communities for several years. He served in the U.S. Army as a Battalion and Brigade Surgeon for 7 years in Operations Iraqi Freedom and Enduring Freedom. Dr. Ferguson has commented on the fact that one of the most impactful times of my life as a physician was in caring for soldiers and their families abroad, end quote. In 2021, Dr. Ferguson started the Black Physicians of Utah in hopes to bridge the gaps of needs for physicians of color for patients, colleagues, hospitals, and medical school recruitment. Since 2021, he has been serving as the Chief Medical Officer for Health Choice Utah. In his spare time, Dr. Ferguson has completed over 40 triathlons and enjoys catching football games with family and friends. Let us welcome Dr. Richard Ferguson.
Thank you. And we're working now. Everybody can hear me all right? Awesome. Well, thanks for that. I also now have another job title. I'm now the interim CMO for University of Utah Health Plan. So just a little bit more work to do with a little bit less pay. So this talk, I was actually very happy that Tony invited me to do this today because it's something that I didn't realize I was advocating or implementing in my daily practice until I started to put this talk and this speech together. And it's also something that is very important to the Black physicians of Utah, and that is the power of family-centered care. And I believe there's been some significant discussions about it earlier today in breakout sessions since the morning. But what I wanted to go through is more of the components, which particular components are most important, how there's barriers to it from a provider and a healthcare system, but also ways that we here as partners, as advocates for families, and particularly for those that are caring for patients at primary care children's, but this also can apply, as I will say, for many aspects of family-centered care, particularly when it comes to elder care, which is something that Black Physicians of Utah also tends to give some more increased focus to. So I thought I'd start off with family and healthcare decisions, something that many of us here, I know there's some case managers, I know there's some physicians, we're very much a part in actively trying to make the best decisions for their quality of care, but also trying to navigate that when you have someone like myself with my day job, which is on the insurance side, making sure, is this medical necessity, is this indicated? And it can be very complicated. It sometimes can be saddening, frustrating, brings people, families to tears. And I've seen it when they just want to do what's right for their child. They just want to do what's right for their mother. And it's hard because of sometimes the mired and bureaucracy and many guidelines and hurdles that people sometimes have to cross just to get a certain drug covered or to get even a child admitted. So I wanted to go through an example of how I saw I would say, a more recent aspect of family-centered care in my emergency medicine practice. So I titled this Confusion, Frustration, and then Relief, because often it's going through those particular stages. And it starts off with, so one of the areas that I practice in is in Cass Lake, Minnesota. Anybody from Minnesota? Heard of it? All right. Do you know where Bemidji is? Okay. So Bemidji State University, I attended my first curling game and I didn't realize they had junior girls hockey leagues starting at the age of like 6. And I'm like, wow, I'm really in a different part of the country. But anyhow, I work in, this is a critical access facility, so it's about 20 minutes outside of Bemidji, Minnesota. It's about 70 miles from the Canadian border. It is an Ojibwe reservation. And as many people may know, one of the unfortunate leading causes of death on many reservations or with many Native American, that many Native American families are experiencing is mental illness and particularly that of suicide rates. And I've run into this a lot because I'm often I'm the first responder or receiver of care when there's mental strife or suicidal ideation. Unfortunately, it has a disproportionate impact and really starts to spike up, as we also see here in Utah, because we unfortunately are leading when it comes to suicide ideation and mental health illness with our children. But particularly, I have a case here where I was in the middle of the day, I think it was about 2 weeks into school starting, and a 14-year-old was brought in by police because they were being bullied already 2 weeks into school. And the teacher noticed that they didn't come back in from recess. And they're like, where's this kid? Class has started, we're into session 4 or period 4. And they go out and the child was attempting to hang themselves a little bit outside the playground area. So you got to think, all right, so if you're 13, what is so bad? What is happening in your family? What is happening that leads one to take this measure to want to end their life? So this child was then brought into me in the ED by police, not a caretaker, not a teacher, for me to evaluate and determine next steps of care. So I got to know this child over the next 2 days and trying to do what was best for them. So one, mom and dad were not in the picture. One, father was incarcerated. Mom was no longer had custody of her child due to substance abuse history. Primary caretaker was the grandmother, and which we often see sometimes that this leads to a generational gap when it comes to taking care of children when substance abuse disorders are involved. So you can imagine the grandmother comes in, she was not aware of her being depressed, sad, or anything, even being bullied at school. So, and then I, being the ED doc at the time, I'm a shift worker, right? So unless I really get case management, social work here at the time, we're doing a proper evaluation. One, this child is alone with a cop sitting outside watching them. So first thing I said, all right, we got to stop that. This is intimidating. This child isn't going to open up. But I didn't want to make any decisions until the grandmother was there, although there was some pressure from my staff to say, we've got an open facility that's in Duluth, 2.5 hours away. I'm like, what? No, let's first figure out what was the impetus for this. Is there any underlying history? Was there anyone else involved? Let's try to better understand the story. So when it comes to dealing with children with pediatric suicidal ideation that unfortunately I've seen often too many times, it wasn't until the aunt came in who had more trust with the particular patient. And then the dynamic shifted from the grandmother, who is the primary caretaker, who has to sign off for all decisions. It was really getting the aunt to be engaged with that decision making. And then that increased the trust, which increased the communication and response and getting the 13-year-old to open up. So over the next 48 hours, because there wasn't really a bed available to send this child to, but the immediate reflexive impact was, let's send them away from their support network, 2.5 hours away, about on a bunch of strangers, and possibly placing them on meds they may not need to be on. So in that time, in working with the caseworker and the social worker that was there on site, that was part of the hospital system, we're actually able to discharge her to home from the ED. But what I took from that is I empowered the family to be an active part of that decision making, and I stopped transfer because I knew strongly taking them away from their aunt and their mom, their primary caretakers, was going to make the child worse off, even though they thought the stranger, the child psychiatrist further away was going to be best for them, even though there had been no prior history. Right now, the child had graduated high school and actually is now applying to nursing school. So it's actually pretty neat to see that and I get updates on her. But what I wanted to just review here is, there was a consideration for placement that I didn't initially like because I didn't have family engagement and trust. Also treatment. Wasn't a big fan of where they were sending her and how long she would likely be away. These kids are often looking at being away for 7-10 days or longer. And then it is a burden often on the family to be able to even get there, because there's this assumption we're doing what's best. We as healthcare professionals knows what's best, not realizing that they don't have a vehicle to go and pick up that child when they're released, which often we, an ED doc, the nurse, often have to take a little bit more time to get that increased communication, but you're not going to get it unless you can get them to trust you. So defining family-centered care, what is the definition? So I see it as a healthcare approach that actively involves families in decision-making and respects their pivotal role in patients' lives. Why is this important? It's particularly crucial in pediatric care and managing chronic illness, but it really applies to any family member that is having a chronic illness and is in an inpatient LTAC or rehab center. So much of what I discussed today can be applied in many care settings. But what's most important is the emotional support and the family well-being when it's in this recovery process. And considering, and it may just be something that may be static for some times. Of course, we know some children will be in the hospital for months and their quality of life may not improve that much even upon discharge. So it's also spending that time to prepare the family, setting those expectations for when they are discharged. So what I really find important here is family-centered care improves healthcare outcomes. How does it do this? What are examples of it? What do we know so far? So family-centered care improves patient adherence by 30%, leading to faster recoveries and fewer complications. It reduces hospital readmissions by about 15%, and providers practicing this will see a 20% increase in patient satisfaction. This, of course, is taken from several pediatric medical center surveys upon discharge. But if we can get this type of small gains just by trying to implement and focus on the components of FCC, this could make us, one, I as the payer will like to see this because this reduces costs of care, but it benefits all. To go into more detail, what is family-centered care? So respect and dignity. So respecting families' beliefs, cultural values, particularly in supportive care. And what I often try to explain to people here is that can occur unless you're regularly collaborating with a family. And it's really about developing that partnership. I might have only had that child there for 2 days, but the fact that I'm now coming back 3 years later, and they're still communicating me and giving me updates. There's that trust that they saw in building a relationship just with an ER doc that doesn't even live in their state. And then also information sharing. That's something that often is remiss or we assume we're doing. So that's providing families with timely, complete, and unbiased information. And then lastly, empowerment. Empowerment, advocacy, or often use these interchangeably during this talk, but empowering families through education and involving them so they can have less anxiety. Because the way the grandmother felt, she just wanted to take her away. As soon as she came in, she just went into protective mode. Why is there a policeman here? This has to stop. So the components. We'll first go through respect and dignity. So in pediatric cancer unit here, culturally sensitive care can involve accommodating dietary restrictions for children undergoing chemotherapy, but also knowing their cultural background when trying to apply those dietary restrictions. So that's just one aspect of how respect and dignity can be applied. Also with collaboration. Get that there. With this, I see often in a children's hospital, there are forms of family, an advisory board where parents help develop policies to improve patient care. So this is, of course, a more high-level view of something that can occur for family-centered care. We're an institution such as primary children's, and it could be something as simple as, do we need to adjust visiting hours on the weekend so that adjusts with parents' work schedules? This is something where it's an example of collaboration. Information sharing. So when it comes to information sharing, I see this as the more transparent you can be, the more reduction in the amount of medical jargon and complicated terminology whenever to explain something to a parent, it will reduce their frustration and reduce that confusion. So as noted here, particularly this has the strongest impact on parents of children with healthcare needs where they often have to juggle multiple specialists. They're taking them to a POEM doc, they're taking them to endocrinology, they're taking them to a pain doc, which I've seen in some patients, particularly some of my sickle cell children that we have to manage here in the state, which there aren't really great specialists for. Most of them are for adults. And so they often are sending a child to an adult hematologist here to know how to manage sickle cell crises in a child. So those are things where just become a parent and make it as front and centered and apparent as possible when just telling them, we don't have a sickle cell specialist here in the state, but we can do our best to make sure they get with a hematologist that has experience in this area. So there are things like, because what we want to avoid trying to do is misleading family members when we think we're doing what's best to, either reduce their fear, but you can still be transparent and information share by still being able to provide reassurance. So, and then empowerment. Teaching parents how to administer certain medical procedures at home. So this can sometimes have the parents feel as though they can do much more in regards to providing care to their child as opposed to being so dependent on, say, a home health nurse or a CNA that's coming to visit. Now, I am a believer in having as much of medical professional guidance or assistance when it comes to complicated chronic illness in pediatric members. But if it leads, I often tell a parent, if we teach you how to do this for 2 hours a day, this will stop. If we can teach you how to dislodge that mucus plug in your child's trach, so instead of us having them to go to the ED, then you're sitting in the ED, exposing your child to further infections, waiting to get an evaluation, and then it may lead to an observation of admission. You're taken off from work, and now everything's been, there's dysfunction that's now been created. But this is an example, just one small example of empowerment that can occur with families. So why does it matter? It enhances emotional well-being for both patients and families. It improves adherence to treatment. Medication adherence is so difficult when you're juggling multiple medications, taking them to specialists. The child doesn't like it, and you're trying to say, all right, do I decide between this pill that's going to make them nauseous, or do I give them their favorite treat? And then you're trying to think, well, I have to think about the emotional well-being of my child as well. This is where you want to make sure that the doc and the care team, they're informed. I do occasionally don't give them this medication. Here are my reasons why, as opposed to us often being viewed as authoritarian, saying if you don't do this, you're a bad parent. And that's what we really need to dispel and stop that. The parent, the family is part of the team. And then also, research has shown that if you practice family-centered care, leads to better long-term outcomes. The benefits for parents and caregivers. So one benefit is enhancing trust and communication. Openly discussing treatment options helps to reduce this anxiety. And Ronald McDonald House actually has an example of this. And so one example is there was a child, and this is from a conference when they were in Curacao that I believe Tony sent me. And a child was undergoing heart surgery and had parents involved in preoperative and postoperative planning. And their participation should reduce their stress and increase their trust in the medical team. And I think that's something we don't consider a lot. We often think about pre-op planning. What do you got to do to get your child to be successful to go through surgery? But really starting to anticipate their care needs afterwards, saying your child is going to be down for a few days. They're going to have a decreased appetite for a few days, as opposed to what often I do in the ED, because we're moving on to the next, giving a sheet that says, please read through these 9 pages. Let my nurse know if you have any questions. And then they're gone. That's something that we want to do to have this. That's an example of transparent communication that we want to occur, especially if there's an operative case occurring where we want to enhance trust. And another example of enhancing trust is a 22 report found that family involvement in decision-making increased trust by 40%. There's not many things that I see will make a 40% change in not necessarily an outcome, but this is in a qualitative satisfaction survey. And when and this is often can be something as simple as inviting the parent to join you on rounds. So this is something that I've seen primary children's actually engage in, but that will sometimes vary depending on the leadership of the team. And so there's even some gaps there depending on which team that needs to be in charge to make sure it is occurring regularly. But this results in improved adherence to post-discharge and care instructions. Once again, having that second-year resident or that intern, or maybe the intern and the second-year resident go through the discharge instructions before it occurs, and making sure that maybe the nurse is available as well, because the nurse has spent far more time than the doc doing a heart and lung exam, examining the wound, doing specialist notes, and then leaving. And so they spend a total of 13 minutes in the room, and then they see them the next morning. It's really trying to maybe engage the nurse, because the nurse has spent more time educating them. So once again, helps to increase trust and communication. Now, for our therapists in here, though many will appreciate this, is one impact is improve emotional and psychological outcomes. And what I mean here is the emotional impact. When the families are part of the care team, they feel less isolated. When they just see a team walking by, they have that 13 minutes in the room, and then they walk away. And then they're just waiting. What is the next procedure? What's the next test? And sometimes all they're doing is just calling the nurse's station or asking the nurse, what's next, what's next? I often, when I was there, I would give the family access to my pager. If they felt like they didn't get a timely response from the nurse, they could reach out to me. Mind you, this only worked when I was on call. Never had anyone abuse it, because they're like, he's a doctor, he's busy. But this definitely made them feel, less isolated. One thing that tends to help with this improving this emotional impact and reducing isolation is getting care management, social work engaged in care earlier as opposed to later. Don't bring in the social work when you perceive there are certain social determinants of health or gaps in care on the day before discharge. Let's try to bring it in earlier. But in the end, it's going to improve quality of care for this family. Recovery impact. So pediatric patients with engaged families show higher rates of emotional resilience, especially chronic illness scenarios where family involvement is ongoing. So another case study here, this is also from the Curacao Conference. And what I particularly noted here is they had less stress, faster recovery. So you're gonna see me mention that a lot. But more importantly, the open communication and having a supportive environment, that's making sure it's a welcoming space for where parents and families can sit, making sure you have enough chairs where the family can gather, having actually a notepad or where they can actually write questions. So that's one thing that I saw one of the primary children's teams do. I would tell them hey, make sure here's a pad, make sure you note several questions you want us to answer for tomorrow, or what may occur. That will make you feel, even if you don't like if you feel that I told them there's no silly question. Especially if I think one person said, can he wear socks? Yes, he can have on socks. But the reason why is that where the child's pulse ox was. So they didn't want to interfere with how the oximetry was being taken. And I said, nope, you're not going to hurt that. It's taped around the toe. It'll be fine. But just simple things like that. All right, and so benefits for healthcare providers, because this is what's important. Because one thing that we face is sometimes something that I allude to, which is burnout. So when you have practicing aspects of family-centered care, you have better provider communication, but you have not only the increased trust between families and healthcare professionals, but we are happier with the care. So I think sometimes we need to realize that if you have more transparent communication, ask that family to be a part of rounds, ask them to write down those questions, we will go home, or we will go writing the notes, especially if it's a very difficult condition, if it's a terminal illness that we're having to explain to a family. It takes a toll on the healthcare provider and the healthcare team as well. We don't like losing children. We don't like losing anyone if we can avoid it. But it's often sometimes the hardest. I think some of my hardest losses is when I had pediatric trauma and I couldn't save kids. Even makes me choke up to this day. Actually, it leads to me sometimes needing to take the next shift off for my own personal health, because it makes me not want to go back into the ED because I feel like I was a failure. And now multiply that amongst an entire care team. That's what some of the benefits we can try to diminish that and reduce that for our healthcare providers with practicing FCC here. So, creating a welcome environment. What are ways we can actually do that? As I kind of alluded to, flexible visiting hours, family-friendly design. So I know sometimes hospitals feel very sterile Primary Children's, I think it does a great job with butterflies and balloons and a nice therapy dog that walks around and wants to be pet. Those things are great. But the thing is, what if you're in a critical access, remote area where you just have a pediatric floor? Should it look exactly like the adult floor? Should it have that same sterile nature? Should there be certain music that's more pleasant? Should there be a game area? Should there be a nice reposit of Dora the Explorer videos to be able, for someone to be able to rent out and check? All of that I know is being done at Primary Children's, but we shouldn't have to always wait to send a child with a family that has limited resources to Primary Children's to get that type of care. This can happen in other facilities. This can happen also at clinics. And then also culturally competent care. I have a whole talk on that, on how racial bias, cultural incompetency leads to decreased trust in communication. But just remember, cultural competence, which the U does require for its residents and its primary care docs as well, that they have to go through every year. But culturally competent care does reduce miscommunication in underserved groups. Sometimes it's just making sure that, do you get an interpreter for their particular language that they may speak in the room with them, or do you want them on an iPad? And involving families, once again, in the care process. So some of those ways, as I've kind of alluded to, is active listening. So we're often used to talking to the family and expecting them to just be okay with it. Family inclusion in the care plan. So let's not wait till discharge when we're talking to them and going over paperwork. And then training the healthcare teams. So we, because I'm part of the faculty here at the Department of Preventative and Family Medicine, part of our education, our lectures, our WATT series that we do with residents that are in training is knowing how best to meet that family member at their level. Do we need to sometimes schedule time with them when you're done making your notes and your rounds? Because you have to get on to other patients and other families at that time. One thing is teaching our residents, our GME trainees, how to communicate effectively. We try to do this with OSCE and certain exams, particularly as medical students. But I think we're under this assumption that they got checked off and they're fine and they're not monitored as much. So I often will tell, when I have, say, a medical student or an intern or someone that's training with me, I have more PA students these days, and I actually see how they communicate to a patient. Are they just reading off of a script? Are they spending a lot of time typing on the computer and occasionally looking over 5 seconds to ask them a question? And how long before they actually make physical contact with the child before examining them? These are all things that leads to effective communication. You want to engender that trust quickly in the room because you want the family to not, no one, I know particularly, people don't want to come see me because I'm in the ER. I'm in often the most expensive part of the hospital. We are sometimes not the most qualified to deal with the myriad of conditions that come in, but yet, and then a lot of people are scared. There's a lot of fear that I address when people come in. They're fearful, like, why is my child turning blue when they cough? Please help me. Okay, well, it can be due to a number of 4 or 5 of these factors. I need your birth history. And so I'm triaging all of this, but how long has it been occurring? Was it just something that happened today? Was it something that they ate? And the thing is, if I don't get the trust of that mom or that parent that's there at the time, that entire visit can go left. And they may be less reluctant to return for further care, which will do what? Lead to a worse healthcare outcome. So it's really important that we get our healthcare teams involved and engaged. So what are some of the common challenges for just trying to actively implement family-centered care? Time constraints. Having a resident, if you have a team, training centers, they often have sometimes more time. You've got sometimes a doc that's in training that can spend 30 minutes in that room after they're done with their notes because there's a whole team taking care of the notes. They have the second-year resident, then the attending note, then the specialist note. So you have these large teams, but when you're not at a training facility and you have just a pediatric hospitalist and there's just 2 of them, the day doc and the evening doc, and they're trying to take care of a kid that has possibly new onset leukemia, and the oncologist only comes in for a very brief amount of time, but they're going to be seeing a different oncologist when they get out. How do you make the difference? How do you create the time? So we have to figure out there are subtle ways. One part of it is the active listening. If they know that you can repeat back what they just said, that often can be enough that they felt like their concerns have been heard. So if you're looking for how to overcome time constraints. And then also differing family opinions. Dad says something different when he comes in versus what mom said who's been there all day. That can often be a difficult barrier. Or the grandparent. So as my first example, the aunt had a better relationship with her niece than the grandparent did with the child. And so there was differing opinions. The grandmother eventually just went with whatever her daughter wanted at the time, the child's aunt. But there was a different opinion from my staff, and actually but social work and all of us came to the same decision. Let's get her supported and have her needs met here at the reservation. But we have to anticipate that. And then this all goes back to a collaborative care model is the solution for when we're trying to address time constraints and differing family opinions. So what are the benefits with FCC for chronic illness? I particularly say family involvement, particularly for conditions such as diabetes or asthma. In a family with, one example is in a family that I took care of dealing with cystic fibrosis, there was better symptom management and emotional support when the family members, this is once again about the mucus plug, when they were trained alongside the respiratory therapist, when instead of the respiratory therapist asking the family to always leave the room. I think it was very important for that RT, and actually this didn't come until the attending said, hey, make sure that the family's in the room and actually have them hold the cannula so they can see how you're sucking, how you're relieving their secretions. This reduced that reliance on the hospital stay. So that's one example. Another is a study on diabetic children revealed that involving families in routine care and checkups reduce hospital admissions by 25%. Making sure they're able to appropriately carb count, knowing that they are able to know if the CGM isn't having effective readings. If it shows 51, but your kid's outside playing around and kicking a ball, and you're looking at the monitor, does that mean you have to rush them to the ED because that's the first 51 that you saw in a while? No, you provide a little education and reassurance to say, give them a snack in about 20 minutes, but once again, treat the symptom, not the number, unless they correlate, because that's something that you need to be aware of. CGM utilization is, they're about to make them over the counter. Everybody in here can go out and buy one and just see how their blood sugar is while they're, pumping iron at the gym. I was talking to you, Greg. All right, so and furthermore in chronic conditions is the family perspective. And particularly here is the families want to continue to, families are often the main advocates for the treatment adherence, dietary changes, and medication schedules. And one thing that we want to understand for pediatric hospitals with the family perspective is the FCC can reduce the hospital stay, as I said, by 15%, but improves the mental health of both children and parents. But emotional impact on families with family-centered care. Reducing stress and anxiety is often key. So when families are included, stress drops significantly. And one particular aspect of this is when the child's condition, or a study has shown that when parents with the children in a NICU showed that 90% reported feeling more secure when regularly updated on their child's condition. So an example, there's a child currently at primary children's that has just had their first, that's had technically 2 birthdays. So they were born there, they were born at the U, and have been there 380 days while waiting for a heart transplant. And this child was born, I believe, 8 weeks early, but had a congenital defect that needs to actually be on a special heart device to continue for the heart to pump because one of their ventricles wasn't fully formed. So that child's gonna have to be there for a very long time in the ICU, not really having significant changes in care. How do you make sure that a family is engaged, knowing that the next day is going to be sustained or better for their child? This is something where the emotional support, getting a therapist in, can make the the biggest difference, a social work being brought in. And then making sure that there is ongoing, so we never want the family to feel as though, once again, this goes back to feelings of isolation, but you never want them to feel that they're external to all the decisions that are being made. So one thing that I spoke about earlier is having a care plan, and particularly a book that you can give to the family. If you're anticipating, I say if the stay is anticipated being longer than 48 hours, that's when I provide them a notebook. And I actually even did this in the ED because often I have to board pediatric psych admits because there's just really hard to send someone. They're either sending them to South Dakota or northern Minnesota, and I have to wait some time. I do the same thing for adult patients. But and mind you, I told them this, I had to go and correct some of them. I'm like, I am not here as your waiter, because they would like write down, I would like cookies, I would like this type of juice. I'm like, this is not what the notebook's for. You're not here to place orders with me. So, but encourage families to maintain a care journal and even providing them with one. And I feel like this is a low-tech solution to what can seem to be a very complicated and stress-inducing problem. So parents as active participants, parent-to-peer support improves healthcare navigation. So what I mean with this is often if you feel like you're not getting through and the child has a form of leukemia, they have to go through a painful bone marrow transplant, maybe connect them with the leukemia support group before they discharge so they can speak with a parent that's already been through that. So that type of peer support can speak so much because now they know they have an ally, they have someone that can help them, and we've seen this also done with type 1 new onset diabetic children that are admitted. And then another part of becoming active participants, besides a journal here, keeping an open dialogue. And I often tell many family members, do not hesitate to ask questions. But I also tell them, if you can wait till sometimes our rounds are over, that's when you ask your questions. But in the care journal, this is where they are, or they're logging their children's symptoms, their medications, and then how they're changing, because sometimes they're not necessarily reporting to the nurse what is happening throughout the day, and this helps a lot. And then, as I close up here, overcoming provider challenges. So what are aspects of that? Lack of time, lack of training, and then lack of institutional management. So an institution can make it a lot easier for the top two. If you have institutional change, if you have a policy that Primary Children's or Intermountain does widely, because they often do pediatric care where else? They take care of kids down in Riverton before they necessarily have to send them up to here. There should be a policy that applies that they may use at Primary Children's that they should apply as well in Riverton. So and then of course the training, when they're rotating residents through, they should go to a community hospital or they should go to AltaView when they have the opportunity so that they know how to best support families when you don't have a team or a gaggle of specialists just going through the hallway, or you have all the special PlayStations and balloon teams and clowns that come through that may be here at primaries. So, success. Involving parents in rounds, this can result in increased treatment adherence, fewer misunderstandings, and more trust with the family. So my key takeaways, I would say, are, I've already repeated a couple times how it reduces readmission rates, increases adherence to therapy, and can reduce the need for specialty care, but also reduces stress, builds trust, and this is essential to pediatric and chronic care. So the call to action that I would say for many here, provider responsibility. So providers should create opportunities for families to engage in care decisions by scheduling regular updates and care meetings. Actionable steps. Implement family advisory boards in hospitals to give families a voice in care policies. These boards provide critical feedback that improve patient outcomes. And then also an example of this that I would say is also make sure that you pay attention to culturally competent care. providers must prioritize cultural sensitivity training to engage underrepresented minority families more effectively. Because for one example, Utah is just going to continue to brown. It's kind of why BPOU is important, to represent and advocate for health equity and the importance of those that are Black and marginalized within our state. This is even more important when it comes to elder and pediatric care. And for families, because families are very much a part of this call to action, advocate for your loved ones. One of our first, I want to say, Instagram lives that myself and Dr. Baden did at the Black Cultural Center just a few blocks from here was on patient advocacy. And we actually did it with a veteran who had to advocate for himself to get a renal transplant because he kept getting dismissed from one specialist to another saying, oh, just give more time. You're not quite at the right level yet. You're not showing enough renal impairment yet. And it wasn't until he brought out a study and he says, this is what's going to happen to me within 2 years unless I'm put on that transplant list. And he advocated for himself, and that helped him to get a transplant a little bit under 3 years later. And then ask questions. This will lead to just letting go so much fear and stress if you can just get up the nerve to ask a question. We want to hear it as providers. We don't want to leave the room knowing we didn't meet your care needs. And then also partner with the healthcare team. This is where I asked to be a part of rounds, so that's okay to do. All they're ever gonna say is no, but it's actually not uncommon. But you gotta make it there because the rounds are often at like 6, 7 a.m. in the morning because labs come back at 5:15. So if you can't be there at that time, but what's another way to do it if you can't physically be there? Leave a message for the nurse. Hey, when they're getting ready to round, can you just notify me or let me know, or I'll just call, and if they're there, can you put me on speaker? So I had someone actually did that where they had a cell phone. They said, can you make sure that my mother is called? And then in conclusion, this is actually until about 2022, because of this is something that's lingered a little bit from my time in the military, is the pediatric care where I didn't feel restricted was actually when I was overseas. So this is here, actually, this is a baby that was in a dry suit a little bit earlier, lifting out of the Mediterranean on a raft at the island of Lesbos about 5 years ago when I was part of a humanitarian mission there. And this is when I spent 3 weeks in the mountains of Leyte in the Philippines managing a pediatric clinic. So I appreciate everyone. Family-centered care is essential because it's important to be compassionate and effective healthcare. And any questions, and I just threw this on here so I could do some shameless plugging for events that BPOU is having come up. Sweet. I hope you learned a little bit. I think it all comes down to wanting to empower the family to ask those questions. And then, something as simple as giving them a notebook and talking to the administrator or the nursing staff that's there is, I know visiting hours are over at 8, but this mom doesn't get off till 7:30. How best can she come up to see your child? This child is under the age of 2. They've never been outside of their home. Is there a way that we can have a chair here so she can stay overnight? Or the mom and dad stay overnight? Or dad comes in at 2 a.m. Simple things like that can make all the world of a difference for a family. All right. Thank you.
Thank you. Ferguson.